I think for well over a decade now, there has been a lot of thought among various leaders in the field that doing many things at the same time in parallel, many types of interventions may be the very best way to treat Alzheimer's disease. It certainly is for a lot of other diseases. You think about how we treat hypertension and diabetes. So looking only for like a silver bullet, like a single pharmaceutical that one would treat Alzheimer's disease is a perfectly reasonable and rational thing to do. But we wanted to investigate the hypothesis, which has been gaining steam, that you should do multimodal interventions. And already we've seen the finger trial, which is a fairly well-known multimodal lifestyle intervention out of Finland that had very promising results. And there's been a need to further test these ideas for a while. And so we set out to test the hypothesis. Does a multimodal lifestyle intervention work for ameliorating Alzheimer's disease? The other thing is I come from the Institute for Systems Biology, and so our main interest at the Institute is to advance systems biology and research. And so we wanted to pair our expertise with dementia expertise. And so one of my main interests, in addition to dementia, is can we learn knowledge in clinical trials in brand new ways, ways that are a little bit different than sort of testing a single piece, a single question in a binary way. Does lecanemab treat Alzheimer's disease? Yes or no? So instead, we wanted to ask, can we use a multimodal intervention to treat Alzheimer's disease? And by the way, how does it work in detail? Through what molecular pathways? And when the trial is over, will we be able to learn enough information from the trial that we can modify the intervention, suggest improvements, and also give us questions and answers to parts of dementia and Alzheimer's research that we didn't even ask, and help other researchers by combining data. So this is a big data trial. In addition to being constructed in sort of a classic prospective RCT randomized controlled trial way, we were also gathering thousands of data points on individuals over time to get a picture of what's going on, a molecular understanding of how the intervention works. The actual intervention for COCO, we have a sister trial, which is a little bit more in person, but is telephonic coaching. So we engaged people on a weekly or at least monthly basis and asked them to change their lifestyle. We wanted them to improve their diet, to do more exercise, to do brain training, usually through Posits Brain HQ, and to anything else that would be personally important to them. If they're exposed to toxins, stop getting exposed to toxins, maybe they need better sleep. But roughly speaking, this was a diet and exercise trial mediated through telephonic coaching. What we saw, and this was a small trial in a specific population in Southern California, but roughly we saw what we expected to see. Trials like the finger trial and other cohort studies had shown a fairly significant and large effect of diet and exercise on dementia. And so we saw the same thing. We saw at 18 months, we saw about a 60% reduction, or rather an improvement in cognition, so a reduction in decline in our cohort, which was an early Alzheimer's disease cohort, sort of what some people might call MCI. And that's a big effect. It shouldn't be surprising because it's what other people have seen, but it's about double the effect that the trials like the lecanemab trial. I think they're going to announce about 30% decline. And so this underscores the need for clinicians and clinical guidelines to really emphasize multimodal lifestyle interventions, and then drugs as an addition to that. Frequently, when you look at these guidelines, it's really the other way around. Lifestyle and interventions are often sort of an added-on afterthought. It's like, oh, by the way, do these things. And it really underscores the need for further research on the topic.